Greetings and welcome to the next edition, our fourth edition of the Gamechanger series of AMR policy webinars. Welcome to all new participants as well as those who are joining once again and have been there in some of our previous webinars. My name is Satyajit Sarkar, Satya for short. I'm the project coordinator as well as the technical lead for policy and advocacy for the RADAAR project. I'm speaking to you from IVI in Seoul, Korea, and I'll be your MC for today's webinar. Well, a big warm welcome to both our speakers who are already there and also our wonderful moderator and discussant, Dr. Gemma Merrett from Wellcome Trust. I would also like to take this opportunity to recognize a very special person who's joined. He's a member of our board of trustees of IVI, Malcolm Sweeney. I don't know him personally, but welcome, Malcolm. So let me just start very quickly with a brief introduction. So the overarching theme of the Gamechanger series, as some of you would know, is to explore innovative ways of leveraging policy-relevant data to drive AMR policy. And over these 6 webinars, we have 11 truly gifted people who will offer some critical reflections and also insights into stopping AMR and various strategies from a range of disciplines and perspectives. The 6 webinars are also moderated by an array of really world-renowned experts, AMR experts, and the topics they're spanning from animal, human, environmental health to socio-behavioral sciences, which was all about it last week, and the emerging fields of artificial intelligence and machine learning. And today it's all about the public and the private sectors, which I will leave Gemma to introduce you to. Each speaker and each webinar will attempt to answer 5 questions through the sessions. That is in relation to AMR. Where are we today? Where do we need to go? How do we get there? What works and how much it's going to cost? The running order and agenda for today is as follows. Besides this brief introduction, we'll have Dr. Catrin Moore come on first from the GRAM project. We have switched the orders today, and she'll be speaking on collaborations and data sharing reflections from the GRAM project. There will be a brief Q&A and discussion between Gemma and Dr. Catrin Moore, and then we'll have Dr. Bruce Altevogt from Pfizer, and he'll speak on the topic collective advantage, collaborations to drive impact. And by collaborations, he primarily means also, I believe, the private and the public sectors. He'll also have a brief Q&A and discussion with Dr. Gemma Buckland, Merrett, and Bruce. And this then will be followed by half an hour of Q&A session with all participants, where we have national, regional, global AMR stakeholders. And I do hope today also some media persons and journalists have joined. Following that, Gemma will do a wrap up with some of the key takeaways from today's session. And don't disappear in the end. Please stay back for 30 seconds more after she wraps up. There's a small participant feedback and evaluation we would like to do, which will not take more than 30 seconds to a minute. So that will be the session and the running order for today. And now a few housekeeping notes. Be assured that a link to the recording of today's sessions will be sent to your registered email. All the previous webinars, we have already sent all the recordings, and in some cases, we're also sending transcripts as we make them. So be assured you'll be getting them, and they're a very valuable resource. Please submit your questions only in the Zoom Q&A box. While you can use the chat, try and send all your questions to any of the speakers or the moderator, only in the Q&A box, and they will be channeled to the moderator. If you would like to specifically make a verbal intervention during the Q&A session, please raise your hand, and at her discretion, Gemma, our moderator, will let you in to make a verbal intervention if you like. With regard to chat, the chat rules we are keeping very simple. We encourage exchanges and comments in the chat box. Please feel free to do that, including raising questions to other participants if you wish. but just keep all your inputs focused on the topic and ongoing discussion, please. That's our only request. So that's as far as housekeeping goes. And now I would like to just introduce our moderator, Dr. Gemma Buckland. I'm sorry, I have to look at my notes a little bit. So Dr. Gemma Buckland Merrett is the research lead for drug-resistant infections at Wellcome Trust, that is. And in her role, she's shaping and delivering Wellcome's antimicrobial resistance strategy and bridging the gap between science and policy. Most enviable job, I must say, and it's excellent. Gemma joined Wellcome in 2019 from Public Health England, where she was the lead epidemiologist for travel-associated infections. And she has over 15 years of experience in multidisciplinary research roles, leading projects spanning public health, epidemiology, and infectious diseases. She has experience working across different sectors and in different countries to advance research for tackling infectious diseases. So I will just shortly hand you over to Gemma to introduce our first speaker and kick off today's session. Just wanted to say we had a few numbers when we last looked. We had participants from 40 plus countries in our previous webinars, so that was very heartening. Though more than 50 plus countries people had registered, but we have 40 plus countries. We shall see at the end of today like how many countries participated. So over to you, Gemma, to introduce our speakers and the session today. Thank you.
Thank you, Satya, for that introduction, and a very warm welcome from me to everyone joining today's webinar. We have a fantastic set of speakers today and a very interesting topic to unpack: the public and private sectors, points of intersection and points of departure. So we do have time for Q&A, as Satya mentioned, after both speakers have presented. So I do encourage you to add your questions into the Q&A chat bar as you listen to the speakers. And also, just to flag to everyone, both of our speakers are working mainly in the AMR response from the human health perspective. So if we could just be mindful of that when it comes to the questions as well, to enable rich discussion. So without further ado, I'm going to introduce the first speaker, Dr. Catrin Moore. Catrin is a research group leader of the Oxford Global Burden of Disease project, supervising a multidisciplinary team at the Big Data Institute and working in partnership with the Institute for Health Metrics and Evaluation, IHME. They are producing data, health metrics, and geospatial maps relating to the global disease burden of antimicrobial resistance. The flagship GRAM project, as it's called, applies methodologies utilised by IHME in its ongoing GBD study to build an evidence base for AMR, with an initial focus on select antibiotic-resistant microorganisms. Catrin has been principal investigator on numerous microbiology studies and primary author on over 10 peer-reviewed publications, including changes in antibiotic resistance in animals. Catrin, it's really wonderful to have you. If you'd like to start sharing your slides, and when you're ready, the floor is yours.
Thank you very much to the organisers for inviting me today to really share with you some of the reflections from the GRAM project on our collaboration and our data sharing over the last few years. And the GRAM project is the Global Research on Antimicrobial Resistance project. As Gemma mentioned, it's in itself is a collaboration, so a partnership between the University of Oxford and the Institute of Health Metrics and Evaluation in Seattle. I'm based in Oxford, and it's also a partnership between the funders. So we're funded by the Fleming Fund, the Wellcome Trust, and the Bill and Melinda Gates Foundation. I have to say that that part of the collaboration works really well. So I just wanted to give us a little bit of background. I'm sure everybody is very much aware of this, but a little bit of background about AMR. And I think this really was discussed very well in the Wellcome Trust report on the global response to AMR, where they described AMR as one of the most complex and multifaceted health challenges facing the global community today. You know, AMR is an umbrella. It covers a number of pathogens and a number of diseases. And then if we drill down to antibiotic resistance particularly, it's very complicated. You know, it is the One Health paradigm. It does cover the environment, animals, and humans. But today I will concentrate just on the human disease because that's what we've been doing within our project. So that's a tiny bit of the background. But also over the last few years, we've seen that AMR has become more of a global concern, and there's more political will about actually backing AMR and looking into this. Here in the UK, we had the O'Neill review was commissioned by our Prime Minister back in 2014, which then we saw a bit of a cascade. We saw the global action plan for AMR, followed by national action plans, bringing AMR to the local local countries to really understand AMR and combat it. Then we had the review on AMR, which was published in 2016, which led to the establishment of the Fleming Fund, followed by the IACG and the One Health Global Leaders Group. And actually this year, we've had AMR on the G7 and the G20 meeting agendas. So it really has started to become a politically discussed subject, and we really need to make sure that we keep that momentum going as we move forward. One of the things that we've seen is that AMR, although was implicitly mentioned in the Sustainable Development Goals, has actually become an indicator within goal number 3. So we now have the indicator where we can look at the percentage of bloodstream infections which are due to selected AMR bacteria, so particularly methicillin-resistant Staph aureus and E.coli, which are resistant to 3rd-generation cephalosporins. And I'll come back to those later as well. What I want to do now is go back to where we were at the beginning of the GRAM project. So the project started in 2017. And the reason, actually you can probably see this, the reason for the project was that actually at the time there was very little information about the geographical distribution on AMR. There were major gaps in the data. We didn't know the extent of resistance, we didn't know the types of resistance, and there wasn't a formal framework really to understand AMR. We had some estimates on the burden of disease from Europe and from America and from our colleagues in Thailand, but those estimates were produced in many different ways. So really we needed a consensus on the diagnostic methodology and the analysis of that data. So hence the GRAM project began in 2017, and as I said, this is a partnership between Oxford and IHME, and our main goals were really to build a comprehensive and up-to-date global synthesis of the data available, to really understand what was causing AMR, the selected bacteria and the resistance that we saw, to then use that data to understand the prevalence of resistance over time and space. So to perform the geospatial mapping. And the time within the global burden study starts from 1990. What we found is actually we have most data from 2000 on for prevalence of resistance. And then, as well as estimating the burden of AMR, bring that into the global burden of disease study. And why global burden of disease study? Well, it's a systematic scientific effort to really quantify the health loss due to different diseases, injuries and risk factors, and then look at that by sex and by age groups in specific years. And that can be visualized on the IHME website, both in a map format. So here we have lower respiratory infections and the changes over time of deaths due to lower respiratory infections on the left-hand side. And then on the right-hand side, this is where we can compare the numbers of deaths. So we have here lower respiratory infections can be compared to TB, can be compared to stroke and ischemic heart disease as well. So it makes it comparable across the different diseases, both infectious and non-infectious diseases. Now, I just wanted to touch on the methods that we're using to estimate AMR. I'm not going to go into great detail here, But what we've found is that we're looking at a population attributable fraction, and we're actually making two comparisons, which have been used by different groups over the period previously. And we're looking at where we have resistant infections, which are replaced by sensitive infections. So in our model, we'd be looking at resistance over sensitive, but also we're looking at all the drug-resistant infections, which are replaced by no infection. So we're comparing resistant to no infection. And what we've done is, together, we've looked at the burden of diseases database, and we've said within that database, which area is really related to AMR? And that really is sepsis. So if somebody has a drug-resistant infection that causes death, they will probably go through the pathway of sepsis. So we've pulled out all of the sepsis disease within that bigger database. And within that sepsis, we then looked at the distribution by infectious syndrome. Was it lower respiratory infection? Was it bloodstream infection? What was the infectious syndrome? We then look at the pathogen distribution. So which pathogen caused that infectious syndrome? And then the burden due to that pathogen. So we're looking at resistance over sensitive in one aspect. And then how many people die? So really, if we take a step back and we think, somebody dies with they have a lower respiratory infection caused by Streptococcus pneumonia, which is non-sensitive to penicillin. That would be in our resistant part of the equation. And then if somebody else has a lower respiratory infection with Streptococcus pneumonia that's sensitive to penicillin, they would be compared. And you might gather from this that actually, as we go down in those numbers, we need huge data to start with. And that's why this is a big data project, because we're looking at huge data, different types of data coming in that we use algorithms and modeling to actually work out to estimate the burden of disease. So that's really an overview. I won't go into results at the moment, but that's the way that we're estimating the burden of AMR. I want to step now to think about the challenge. So we know we need lots of data. We know that data gets split in many different ways. What data do we need? Ideally, we would like to have a database that has a line for each patient in that database, which means that we can really understand that data. And that would be having clinical data on a patient, having the microbiology data, and the outcome data, whether the patient lived or died. This really gives us rich information to understand what's happening. And also, because it's big data, it means that we can see connections between that data that we wouldn't have been able to see before. In practice, often we have aggregate data, so that's many people with the same disease pulled up together, aggregated together, which also is extremely useful for our models. And so we really would like really big data, really good data. We'd really like all of that data linked together. What we see in practice is that the data is siloed. So often you have microbiology data in one database, hospital and clinical data in a different database, mortality separate, and then surveillance data separate again. There have been many initiatives, certainly over the pandemic period, where these databases are starting to be linked up. And I think it would be fantastic if we could really make the most of that and bring that into the AMR world. I should also mention this is talking about electronic data, but a lot of the problems that we have in many countries is that data actually isn't available electronically. It's still on paper format, particularly the clinical information. And we've been working very closely with MAP and Captura, who are funded by the Fleming Fund, to bring some of this data into an electronic format, which can then be shared more widely, both with ministries of health and globally. So that we have the estimate, the challenge. What I want to do now is move on to outline our work on modelling the prevalence of resistance, which is really our output in Oxford, our major output. And the data that we use for this modelling is the microbiology data, which luckily is the most rich data that's available. And in order to inform our models, we've collected that data through many collaborations between researchers and hospitals and private laboratories worldwide, particularly thinking about lower and middle income countries where the data is quite sparse. Also through surveillance reports, such as GLASS and the WHO reports, and through industry, which Bruce will also talk about. But within the GRAM project, we've been reaching out to people like Pfizer, who've released the Atlas data freely, but also Becton Dickinson, GSK and Merck to really understand that data, and the Sentry data as well, because that has data not just in high income countries, but low income countries as well. And key to that work is Andy Sagachis, who's based in the Washington University. And we've been able to gather some really some really good databases through those collaborations. And what we've done is supplement that information with systematic reviews where the data hasn't been available. So particularly thinking about Africa, where there has been very little information available. What I want to show here is, as I mentioned, our collaboration. So we have our challenges, we have our problems. Some of our solutions have been collaborations. And here I'm showing collaborations with single sites in the blue squares. And those single sites may actually be many different sites, but within the same country. For example, we've got a collaboration within Laos who work with many different hospitals in Laos. But we also have collaborations with multi-centre projects. And some of these, such as the GARD-P project in dark blue here, have over 80 collaborators within their network, then we collaborate with them. Also, the INIC network has over 60 different countries involved in their collaboration. And this really has been key to actually giving us really rich data. So in all, we have, I think, about 50 collaborations set up between the different researchers and private laboratories and hospitals that we work with. So just moving on to the prevalence of resistance work, I wanted to show you here, this is actually the data availability for those two indicators within the SDG. So Staph aureus and Methicillin resistance and E. coli with third generation cephalosporin resistance. And what we have here is a map showing the grey area where we don't have any data from 2000 to 2018, so 18 years worth of data. And where we have less data, so in the yellow here, we have 1 year of data over that time period. So this informs us when we're looking at our modelling results as well. And places like the EU, Australia, we have very, very rich data on resistance and how resistance has changed over time. So moving on to some of our modelling results. For MRSA, I'm showing in 5-year bins here, 2000, 2005, 10 and 15. And this is showing the change of resistance, where there's less resistance in the yellow and more resistance with the purple. And what we do is we collate the data, analyze it, and then model that data using machine learning algorithms. And we see the change in resistance over time. for example, Central and Southern America has more resistance over time. But the UK here, you can see, begins with quite a high resistance, and over time that drops. So it really can help to inform us on a policy stage. And I want to share with you the 2018 results on MRSA. And what I want to look here is where we have high resistance in our maps for 2018. This is actually informed by high resistance in the data. So it's not an artifact through the modelling. It actually shows that we have high resistance due to the data available. And then the same for E. coli with third generation resistance. And we know that third generation cephalosporin resistance is on the WHO global priority list. So it's important to see how resistance has changed over time. And you can see for some countries, such as India here, the resistance was high 20 years ago and has remained high over that time period. And then if we look at 2018, the same, that the resistance in India is informed by data, and other countries where there's high resistance, it's informed by the data. And this data consists of over 4 million data, 4 million isolates in this resistance map. Then moving on, so what do I think our priority action areas are going forward? I think we've now got our first estimates. I would hasten to say that these can be made better with more data, with better data, but we do have our first estimates, and we need to use this data, this evidence, to really move into action. As Jim O'Neill said a couple of weeks ago, we have that information. We now need to action it. We now need to take that forward. We need to have a continuous quality improvement. We know that the data that we have in the GRAM project is probably the tip of the iceberg, and that there's much more data available, but we need more collaboration to make that data available. We also need to improve our diagnostic capacity. So it's impossible to get microbiology data if a microbiology lab is not present. It's difficult to understand that data without the data management, the analysis and the interpretation. So all of those need to be improved in many, many different countries. And we've been working very closely with lower and middle income countries to try to build this capacity if possible. What we know is that AMR doesn't exist on its own, that we need a lot more information on antimicrobial use and consumption. And we've been working very closely with one of the industry partners, IQVIA, who have fantastic information on antimicrobial usage. And we've used that in some of our modelling for antimicrobial resistance. There are obviously many limitations to the work that we've done. One of those being data seeking. It would be really useful to understand how far people have to travel to go to hospital and where they go in between. That at the moment is a question mark for us within the GRAM project. And I've got a couple of slides to end, Gemma. I just want to thank all of our collaborators without whom we couldn't be doing this work. They're thanked very much on our website, and we've been working with them to really understand some of the stories behind the work that they do. So we have a blog page where some of our collaborators have really described their day-to-day work and their work with AMR. And also the team, the GRAM team. This is not a one-person project. Many, many people work on the project. Mohsen Nagavi and Chris Murray are the leads in IHME, but we've got a number of people here in Oxford who've been working on this. So thank you very much.
Thank you, Catrin. It was fantastic, a really rich presentation. And we're all eagerly awaiting the final results of the GRAM project as well. So very much looking forward to seeing that publication. I'm sure there's going to be a lot of questions from the audience on this, and we will get to those once Bruce has spoken. But if I may, I've got a couple of very quick questions for you. It was really fantastic to see the breadth of collaboration for the GRAM project, and it's clearly benefited with regards to all the data sharing. And you did emphasise the need for collaboration in your final slide as well. And I was wondering if you could talk us through some of the priority collaborations you would like to see when it comes to tackling AMR from that data perspective in the future.
Yeah, it's a really good question, Gemma. You know, the project as is, that's the first step. It really does need to expand and move forward. So there are a few collaborators that I think we should be reaching out to, and all of this takes time as well. I didn't mention that 50 collaborations over 4 years is a fantastic effort by our team. There are public health networks that I know of that we've reached out to, but they've been swamped with COVID. And I think we should be reaching out to more of those public health networks. There's the International Association of National Public Health Institutes that has a fantastic network. And they have networks all over the world. So I think we should really reach out to them and engage with them much better. I think also that the one thing, the Fleming Fund and MAP and Captura really have been reaching out to ministries of health. And I think we should really reach out to them in an engagement exercise so that they can make use of the data that we have, and then they can derive action from that data. So it would be really good to see more interaction between the GRAM, maybe even the WHO and ministries of health in that area. And also industries. As I mentioned, we've had some real success stories, particularly for the both the AMR side, so resistance data, and the antimicrobial use data. But also one of our industry collaborators gave us some fantastically rich data from a high-income country that really informed the modelling that we were able to do. So, you know, without that, it would have been really quite difficult. And then the other thing is private laboratories. So I did mention them briefly, but within Africa, we've been working with one of the private laboratories, the Lancet laboratories, who have a fantastic network across Africa, and that gives us very good microbiology data. But there I'm concentrating on microbiology because the clinical information is lacking in many of those laboratories. And you know, if I were to have a wish list, I want to have more clinical information to feed into this work.
Yeah, absolutely. Thank you. That's really useful. And maybe this is something that we might expand on in the later discussion, but given the breadth of collaboration that you experienced with GRAM, could you share some of the lessons that you learned through collaboration and what really worked and perhaps what didn't?
Yeah, happy to. So if I think about what worked first, as I said, it's it can be quite a long process. So building the trust works, working together with that collaborator, understanding their problems prior to engaging with them. Personally, I think being a researcher really quite helped, and myself and some of my team members, so Christiane and others, we've been working in lower middle income countries. I was based in Southeast Asia for 6 years running microbiology labs, so I understand those problems. And I think from that point of view, that really, really helps. And I think also that there's a trust in what the group does, because the Global Burden of Disease study has been running many years. So there's a trust in knowing that they're experienced in their work and leaders in the work that they do. And I think that there's a buy-in. People want to have AMR comparable to other diseases. So there's a real, want to share that data to see what it looks like in their country as well, to make it local for them. I think most people know about GBD, so that was quite helpful. And I think because policymakers will use this data locally, I think all of those are drivers to share the data. On a process side, we started with nothing, but actually setting up collaboration agreements, having processes and protocols and ethics really help the whole process. So by the end of the 4 years, you know, we know where we're going with things. It's made much easier for that reason. And then if I move on to the what didn't work so well, or some of the problems that we faced maybe, I know that the people were sort of wary of sharing their data, partly because we're two big institutes and people were worried about sharing and having the data interpreted in a different way to how they might have interpreted it. And, you know, because we were working with researchers obviously, and importantly, they want to get their data published before they share it. So they were not so happy to share before their data was published. We have actually been working with researchers where we embargo their data so that they share it, but we don't openly publish that. So there's the researchers, but also, you know, these researchers have been working in these countries for many years and they have fantastic databases, and that's their work, you know, their institute's work. And they then feel that they don't really want to share that quite so easily. So there are many discussions that work that we discuss with those researchers. There's also, although researchers and institutes want to share, perhaps when it gets further up the chain, it gets more difficult to share. And many of the ways around that is to aggregate the data so that we only receive the aggregated data. I think time is a really big and important thing that we should think about, because it does take time to engage with people to learn about their concerns and really understand what they want out of this. And we're on a grant, we're a research project, so we only have a certain amount of time to do this work. So as I said, you know, this is the first step, but there will be more to come, I would say. Yeah. Then I can move on to the data, the different way they're saved, the different way they're shared. Here in Graham, we decided very early on that we wouldn't ask the collaborators to fill in a separate data sheet. They would share the data that they have in the way that they have it, which then put the onus on us to harmonise that data, which is a big part of what we've been doing, really. I think I'll stop there rather than carrying on.
There's lots to unpack, and perhaps we can come back to this one. That was fantastic, though. Thank you so much, Catrin. So I'm going to introduce Bruce now, our next speaker, Bruce Altevogt. Bruce is Vice President and Head of External Medical Engagement within Pfizer's Hospital Business Unit. And the External Medical Engagement team supports the industry-leading antimicrobial resistance surveillance program called ATLAS. Prior to this role, Bruce was Senior Director of Science Policy and Science Advocacy and was lead for AMR Policy, also at Pfizer. He serves as a member of the AMR Alliance Board, an organisation that measures and drives the life sciences industry progress to curb AMR. It's really great to have you here, Bruce. If you'd like to get ready and share your slides. In the meantime, I'd just like to remind all of our participants to post Q&As in the chat to enable us to have a very rich discussion after Bruce has finished presenting. And when you're ready, Bruce, the floor is yours.
Thank you very much. So I think I messed up the screen share. Of course, I apologize. Good morning and good evening, everybody. It's a great pleasure to be able to join everybody today. And I had made the suggestion that I follow Catrin because I felt her presentation would set me up well. And now I'm actually quite anxious having to follow such a great set of remarks, but I will do my best. I wanted to spend the next 15, 20 minutes or so, provide a little bit of background and perspective on where and how industry is looking at some of these problems, the commitment that Pfizer has made to address AMR, and how we translate that commitment into collective action and into supporting public-private partnerships to address this work going forward. So I think we certainly have heard from, and this probably isn't new to many people, about the critical importance that antibiotics have and how they truly have enabled the practice of modern medicine since the introduction of antibiotics. You can see that the rates of mortality have decreased, for example, from 100% of people with heart valve replacements to just 25% as a result of the introduction of antibiotics. You can see that for many different disease areas. These are critical. They are drivers, they are enablers, and we must treat them as such. However, at the same time, with the introduction of antibiotics, we also see that resistance occurs very quickly. Some of these rates, unfortunately, were in sometimes were from 1972 until about 2002. There was a long delay. Many of these lines are becoming more steep, and that is also driving the problem that we have. Certainly, the WHO has helped us identify what are the priority pathogens that we need to be addressing as industry and developing new antibiotics, and we do so. But it's not sufficient, right? We have seen from Pew Charitable Trust in their analysis of the current antibiotics pipeline that was released in April of this year, that there are currently only 43 antibiotics in clinical development. Many of these are still in phase 1 or phase 2. What that means is they're still 5-10 years from being into a patient, even if they are successful. Of these 43, only 15 of them are really addressing the critical pathogens. So we as industry need to do more. And it's with that I want to transition to what we do at Pfizer. Certainly we have a commitment to drive continued research and development for new antimicrobials. We have a legacy here. Our legacy dates back to literally our first product back in the 1850s was Santonin, which was a deworming medicine. And during World War II, we were the largest producer of penicillin, and now we have one of the largest and most diverse portfolios of antibiotics and continued commitments to, again, go far beyond just supplying antibiotics to the community. These commitments are broad. As I mentioned, certainly we focus in on research and development, the need for new business models, committing to supporting new research and development. However, that is just one piece of the puzzle, and it's one piece of the puzzle that industry can take on. Other areas that industry needs to and has to support, and which we at Pfizer do, focus on vaccines. What is the role of vaccines as prevention of the infections so that the patients don't even need to get antibiotics? How can we improve our manufacturing practices to minimize the waste that goes into the environment? Stewardship is absolutely critical and something that I will be speaking about much more later in this presentation about what and how industry can support and ensure the appropriate use of the medicines that the community has. Surveillance, we've already heard from Catrin about the important role of surveillance, and I'll speak to this further. And then, of course, in regulatory. So all of these are areas and ways in which we at Pfizer commit to address AMR. These commitments we've put in paper. We have signed on to through the AMR industry declaration and the AMR industry roadmap, which were published back in 2016, talking about how we commit as a company to support measures to reduce environmental impact, committing that antibiotics only be used in patients who need them, aligning promotional activities with appropriate use. So, for example, we've decoupled sales incentives in our sales force in some countries, whereby they are not receiving bonuses on the volume of antibiotics they sell, partnering with stakeholders to improve access to our medicines and diagnostics, and advancing R&D through collaborations. All of this work is really being led by the AMR Industry Alliance. You heard from Gemma in the introduction to me that I serve on the board. This is an organization that brings together over 100 companies, trade associations to align and ensure that we are meeting the commitments that we signed on to through the AMR Declaration back in 2016. We're very grateful that our commitment has been recognized by external stakeholders, including the Access to Medicine Foundation. In their most recent report in 2020, they recognized us as one of the leading pharmaceutical companies in infectious diseases. And we were especially proud that we were ranked #1 for stewardship of all companies. And I think that, again, speaks volumes to how we organize and run our business. Just a heads up, I believe the next iteration of their report will be released in the next month or so. So be on the lookout for that, and we're anxious to see those results. So just transitioning now, I'd like to spend the remainder of this presentation to provide you some overview of a couple different partnerships that we have to focus our work. The first here that I wanted to highlight is the work that we're doing in India with the Indian Council of Medical Research, ICMR. And I apologize, my dog has a cough, so if you're hearing that in the background, I apologize for that. So this work that we're doing in India is focused on 3 different pillars. And it's, again, another example of a nice public-private partnership to address how we can improve AMR and awareness on AMR. The first pillar is about enhancing and strengthening the existing surveillance platforms that are in India, where and how we can work and partner with different organizations within India, with different care providers to ensure that there is broad collection of surveillance or of resistance data, and that data is being leveraged to inform practice and inform stewardship policies. Expanding stewardship and infection control programs through partnerships is absolutely critical and another key pillar of this platform that we have with the ICMR. And then finally, the need to strengthen awareness and working with ICMR to support one of the first and largest media campaigns that's focused on this, that was released about a year or 2 ago, talking about the importance of stopping AMR together and the different roles that the public and the individual citizens can take to address and ensure appropriate use of the medicines. The partnerships are certainly innovative in this sense and grounded in collaboration with experts. And I think that's really critical as one of what makes these successful and what helps ensure that we can work together across different sectors and identify the opportunities and the areas of interest, the areas of focus that really align to support collaborations. The next, I wanted to transition and speak about the work that we do around surveillance. Catrin briefly highlighted our Atlas surveillance platform, which we're very proud of, and how we leverage that to ensure, again, that the broader community has access to the information and data. Again, I think this is probably a lot of repeat from what she mentioned, so I'll just briefly, skip this slide, but certainly there's significant value and the importance of understanding the resistance patterns, how they change, and it has a very important impact on policy and on provision of care. So at Pfizer, we have the Atlas surveillance program, Antimicrobial Testing, Leadership, and Surveillance. And Atlas is, actually this slide is now out of date, so it's actually about 17 years of data that we've been collecting, looking at how bacteria are resistant. Last year, we were proud to actually be the first company to integrate and support the alignment of antifungal information and fungal resistance into our platform as well. And the platform includes over 9 years of that data. We support strain expansion through Atlas. I think this is something that we don't talk about enough, quite honestly, but our program is not just about aligning to the antibiotics and the resistance patterns that are focused to our antibiotics, but we, in 2018, expanded, almost doubled the number of strains that we are collecting, looking at the WHO priority pathogens, and now address 9 out of the 13 WHO priority pathogens within the Atlas platform. We provide through Atlas, it's free access to the data. And so you can do those, you can look at the emergence of resistance patterns as we saw in the last talk. You can access it through a web portal, through your phone. So, we certainly have heard from providers about the value that this has when they're treating patients at the bedside. And you can analyze the data, not just through the Atlas platform, but as mentioned, we also have been a contributor to our raw data, ensuring that the research community has access to our raw data, because we believe the power of the science, and we need to ensure that researchers can use the data to better inform the research questions in general. different types of formats you can take. I'll just skip this. Heat maps, again, we saw this in the last presentation. So as we think about Atlas and we think about where and how we can expand on our leadership in the surveillance space, I wanted to also lastly introduce SPIDAAR, which is our surveillance partnership to improve data for action in sub-Saharan Africa. Our Atlas platform has a global reach, 241 centers globally in well over 50 countries. Each of these blue triangles represent the number of collection sites we have in each country. The purple dots are the glass enrolled countries, and then finally the stars are where Atlas is. And you'll see the large distribution of where we are. However, if you were to zoom in on Africa, it also drastically shows where we are not. So we only have 3 active countries within Africa for Atlas. And it was with that we said to ourselves, we need to take a step back and really think about what it means to be committed to providing surveillance data. Certainly the Atlas platform and the program and the reason we initiated our surveillance work is to meet regulatory requirements. And so what you see in terms of where we are active is kind of a reflection of where we are in terms of a company and where we have regulatory requirements to collect that data. But our commitments need to go beyond just meeting regulatory requirements, and where and how can we address the needs of Africa. And so that's how we started this. We initiated conversations with the Wellcome Trust and established the SPIDAAR partnership with the goal of creating a scalable surveillance platform that's supported by a robust public-private partnership. And this is absolutely critical to expand AMR resistance data, strengthen public health capacity, and most importantly, improve patient outcomes in low and middle income countries. We initially focusing this work on 4 countries in Africa: Ghana, Kenya, Malawi, and Uganda. And there are 2 important pillars to this work. One is a kind of a traditional, if you will, surveillance capability, where we are establishing 2 collection sites in each country, working through their national reference labs, and using our core methodology to support the collection of resistance data. The second actually speaks to one of the challenges that Catrin brought up during the Q&A around the focus on more outcome data. So we've also established as a component of SPIDAAR a real-world evidence study. This is, I think, the first industry-supported real-world evidence study in Africa that will link and provide us better information about patient outcomes within the settings. But very key, again, is the partnership, and it's been an absolute pleasure to work with Gemma and the Wellcome Trust and to see their commitment to trying a new model. But not only is it a partnership with Wellcome Trust, but it's also a partnership with the CDC, CEDRIC, and most importantly, our government partners in Ghana, Kenya, Malawi, and Uganda. So just a very quick overview of what we're doing through our surveillance hub of SPIDAAR. Again, it's designed to provide high-level, high-quality data using an established methodology at the national level. There are 2 collection sites per country, so 8 total. And testing is conducted in a central laboratory out of South Africa. It combines high-level microbiology methodology, focusing on and also adding in epidemiology and patient outcome research. So again, trying to link and provide more information about not just resistance patterns, but how those resistance patterns impact the patient outcomes. We're in a pilot phase with the hopes that there's potential for expansion into other regions and other countries, pending resources, of course. The real-world evidence study is, again, an opportunity to gather and integrate real-world data to explore the impact of AMR on patient outcomes, looking at patient demographics, clinical and economic outcome data to assess the influence of AMR on mortality and morbidity, length of hospital stay, healthcare costs, etc. We certainly hope that this information and data collected through the real-world evidence study will inform stewardship efforts and support local treatment guidelines. And again, I think the second aim, kind of broader aim, is to also ensure that we're providing the research community and the countries with increased capacity so that they can do this analysis and do this work themselves. So a lot of what this work is, it's not just about collecting the data, but strengthening the capacity within the countries. So what can we achieve together, and why is collaboration important? Why didn't we at Pfizer just go off and invest more in Atlas and do it on our own? And I think there are many important points to consider. Certainly improving data and the infrastructure in the regions with limited capacity and surveillance capacity. Many of these countries had very little capacity to perform surveillance when we started. Provide systematic data that informs appropriate use of antimicrobials and helps drive policy reforms, improving access to data, developing a uniform surveillance protocol that integrates clinical, laboratory, and demographic data, and really trying to centralize that process and systemize and make it more consistent. Establishing a framework that demonstrates the value proposition of partnerships, creating a platform that's scalable and can be augmented. We certainly recognize that this may not be the right fit for everybody. But most importantly, it's about improving the outcomes for the patients. And I think we always have to bear in mind that when we're talking about anything around antimicrobial resistance, we're talking about what this means to the patient and what this means to my mom, to my daughter, to my cousin, to my neighbor, and why we are doing this for them. So just to close, we all can support collaboration by building greater trust, being more clear about our intentions, seeing partnerships and not silos, through greater transparency and seeking out the yes and avoiding the no's. Through all of these key points, I think will enable the industry to work more and work better and more constructively with government partners, with academic partners, and with other funding organizations. And I think we all need to bear in mind some of these 5 bullets and certainly more, and think about how we can improve the way in which we work together so that we're meeting the needs of the patient. So with that, Gemma, I'll stop, and I look forward to answering questions.
Thank you so much, Bruce. That was really, really interesting, and it's fantastic to see the scope of work that Pfizer is involved in. Whilst we wait for some more questions to come through from our audience, I'm going to take the opportunity to ask you a couple myself. Your final slide is really interesting about how we can build collective action, and in particular focusing on partnerships. And I guess for an outsider, there may be a perceived tension for industry working in collaborations with some partners, in particular perhaps governments. So in reality, how have you actually managed to navigate this and create the trust and transparency that's really essential for an effective partnership?
Yeah, it's a great question. And I think it starts with transparency, right? I mean, it starts with being very upfront and honest with your potential partners about what you're doing and why you're trying to do it. And I think you need to come around the table and have those conversations together to understand where each of you are coming from. Now, while each partner doesn't necessarily have to have the exact same desired outcome, those desired outcomes and goals need to be aligned. And as long as they're aligned, there's opportunity to then say, okay, we have a set of aligned objectives here. Let's commit to working harder and working better, because through collective action, it's more effective and more efficient, and you'll have better outcomes because we can leverage each of our areas of expertise. So really coming together around the table, being transparent about those objectives, and being also transparent about what the commitment is. With SPIDAAR, we've had to be very honest. This isn't a long-term investment by Pfizer. We've been very clear that we are setting this out and for an initial 3 to 5 year commitment. And I think setting out those expectations also, again, being transparent from the start, has ensured that there's more honesty and trust in the more difficult conversations that arise.
Thanks, that's great. And thinking about collaborations and partnerships, do you feel that we're getting the scale and the scope right at the moment? Are we including all of the stakeholders that we need to? And perhaps where could we as an AMR community be doing more to create these effective broad partnerships that we need to see?
I don't think we're doing enough. I think we're starting. I think we've seen some good proofs of principle. I provided a couple examples here. There's certainly other examples from other companies. But all too often, we set up structures that do not allow cross-pollination across the different sectors. And we think about what are potential conflicts of interest and perceived biases and perceived conflicts, and decide to shut the door without first thinking about how can we work together and improve this. And I strongly believe that it's only through collective action that we are going to be able to tackle this. Every sector has a role in this work. That's been very clear. I don't think anyone would argue with that. But it's also each sector has something special they can offer to the solution. And by working together and leveraging each of our areas of expertise, it's only additive. It doesn't subtract. And we need to be willing as organizations to take the risk to partner, as Wellcome did. I mean, right, let's be honest, it wasn't necessarily easy for Wellcome to say we're going to step in and partner with someone in the private sector. So you need to have a willingness and be able to take some risks. But I think those risks are worth it as we think about what it means for our provider and patient communities.
Fantastic. Thank you, Bruce. I think it's now time to give the audience a chance to ask some of their questions. So could I ask Catrin to come back onto camera, please? Brilliant. Okay, so we've got some questions coming in from the audience. We've got a first one here for Catrin. So Catrin, could you give us a few examples of how exactly some countries may be using gram data? Or how is the global/international community using some of this data?
So I thought about this. In a way, it's a little bit preemptive because we have our paper coming out in the next couple of months. So I think that's really when the data will start being used, is when that paper comes out and we release the data onto the website and things. I think that's when we will really see an uptake and people will start asking questions about what's happening in their countries and things. I could make a guess that our collaborators are already using that data and are working with the data that they prepared and sent to us. The one thing I can think of is that with the antimicrobial usage data, I have been asked to share data for specific countries through the Fleming Fund. So I work with many of the countries. I'm on the country calls in the Fleming Fund, and some of them have asked, well, what about the antibiotic usage over time in our country? And I've shared that data, and they've been able to use that within some of their presentations and their analyses as well. So I think a little bit preemptive, and watch this space.
Yeah, thank you. And maybe just to follow on, we have a question about how useful this data is to the local situation. So our question comes from someone who has in mind the India situation where cephalosporin resistance has been high for more than 10 years.
Yeah, it's a good question. I think, again, it will be a case of we have a big picture, but I think the local picture is actually much more important, and we need more local data to actually inform those models. With, the big picture as the start, I would say. We are working ourselves with ICMR and research groups within India to bring their data into this to really inform the models. So hopefully we will get a much better picture within India. But that's just one of many countries.
Absolutely. I think
if I can add in there, I think this speaks to where we are currently as a community and where we need to move as a community around surveillance, right? So much of our surveillance is focused at the national level, and it's understandable. It's easier to do. The resources required to really hone in on individual city or county municipality data is difficult and challenging. But we do need to ensure that the provider community understands the resistance patterns, not just annually, but in real time. And think about how we can improve real-time access to resistance information. We have some partnerships actually in some countries in Europe where we're piloting a program to improve that and to ensure that some hospitals have the tools they need to analyze the data. So often we're finding, even in high-income countries, that the provider communities at the hospitals don't even have the capabilities to do those real-time analytics. So it really kind of speaks to some of the broader challenges that we need to be thinking about from a healthcare capacity standpoint.
Bruce, I think that's absolutely right. I think the importance is now, part of that action should be taking it locally so that the local staff can improve their patients or the delivery of healthcare to the patients. And I think part of that may be algorithms to understand what they're seeing and seeing the data maybe on a monthly basis within the hospital, seeing how the antibiotic use, antibiotic resistance is changing. One project that we're starting up is called the ADILA project, where we're looking at antibiotic use locally in a number of countries and actually understanding what should change, what should the empiric guideline be based upon the antibiotic resistance locally. I think that's the next step here.
Yeah, completely agree, Catrin. There's a question here for Bruce, specifically about SPIDAAR and how that data is being used, what's happening to that data. Could you maybe touch on that a bit, Bruce?
Yeah, it's a wonderful question. And I should be very clear, and I apologize I wasn't. At this point, we still don't have the data from SPIDAAR. So this partnership was launched last year. So we have just started isolate collection and analysis in the last several months. That data will not be available until we have enough data to put it up and make it available. It will be made available through the Atlas platform and then also through our commitments to ODI for research access. And then the real world evidence study, we literally just had our first patient enrolled in this past week. So that data won't be available. That study won't be completed for another year and a half or so. But and Gemma, I'd actually turn this back to you. One of the key components of this is ensuring that the local community has the ability to perform the analyses themselves and do the research themselves to support the data for action. I don't know if you wanted to actually speak to some of the work that Wellcome is committed to in this space to support and enable that data analyses at the local level.
Yeah, thanks, Bruce. I mean, it's an incredibly important point and one that has been raised numerous times today. Data generation is one thing, but we actually need to see that data being used. And one of the gaps that we see is the ability to actually analyze and the availability of tools to do that. So I think for the SPIDAAR project, Wellcome is definitely stepping in to provide some training there, and also to help both on the research capacity side, but also on the policy capacity side there. So the policymakers can actually look at this and understand what they're seeing and what they need to do with it. And we also have some other projects in our portfolio at Wellcome that are focused on how we can actually understand data and make it useful for patients. It's an incredibly important area, and I think we really need to see more in this space. We also have another question that I think is slightly related to SPIDAAR. One for you, Bruce. It's whether SPIDAAR data will be used to inform and review WHO priority pathogen lists, which is currently something that we see focused mainly on high-income countries. And then a second part to that question is, isn't it perhaps time that pharma industry looked into new alternative models away from the clearly failing market-based models for financing that are more public needs driven? So two quite different questions there for you, Bruce.
Yeah, let me start with the first, and I may ask you to repeat the second one once I'm done with the first. My hope and expectation is that the data from SPIDAAR helps inform the broader community. I can't speak to exactly and specifically on behalf of the WHO and where and how they would want to use the data. I think hopefully these data will be of value and use when they do a second analysis of the priority pathogen list, and they'll have access to more information from Africa. That's, again, there's a gap, there's a need. Certainly, it's not just the SPIDAAR program, right? We're seeing more countries supporting data collection now. We're seeing the Fleming Fund do more. So it's certainly not just SPIDAAR, and I don't want to make have the community think that it's just us and just this partnership. We need more work by everybody. But I do have a hope that this data will be used by the public health community. I think it raises questions about what is the role of pharma and pharma data into platforms like GLASS. Are there ways in which we can better integrate public data and private data, like what's being done through IHME? But are there some broader platforms that we can think that will support and enable integration of this? There's certainly there's certainly some challenges, right? You don't want to double count, etc. But those can all be overcome. And I think we have a responsibility as a community to work together to think about how to integrate data from the private sector and the public sector to support the most robust information we have. Gemma, I don't know if you wanted to come, if you don't mind repeating the second half of the question.
Yeah, before I do, actually, I might just go to Catrin to get her views on the industry data then, because obviously it was incredibly useful for the GRAM study. So Catrin, would you be able to share your thoughts on sort of the integration point there that Bruce raised?
I couldn't agree more. That's the simple fact. It's breaking down those silos and making sure that it can be shared, I think. It takes, going back to it, takes a long time to sort these things out, be it data use agreement, be it collaboration agreement. All of these things need sorted out, and different industries, different partners have different ways of collaborating with each other. I think we're in a good place. Everybody wants to collaborate, but it's just breaking those barriers to do so.
Yeah, absolutely. Great. So let's just go to that second part of the question then, Bruce. So isn't it perhaps time that pharma industry looked into new alternative models away from the clearly failing market-based models for financing and models that are more public health needs driven?
I'm just trying to interpret the question, but if this is focused on models to support investment in research and development, couldn't agree more. I think we absolutely need to be thinking about ways in which we within industry and in partnership with governments can sustainably support long-term research and development to bring the antibiotics of need to the patient community. We see some examples of this. There's a new pilot within the United Kingdom that's focused on a new sort of reimbursement model that actually at its core is focused on stewardship and ensuring appropriate use and access to the medicines while still securing enough of a return to justify continued commercialization and access to the antibiotics. There are ongoing policy discussions in the United States, at the EU, again, thinking about models by which you can incentivize companies to support the significant investment that's needed to bring a new antibiotic to market while ensuring access and while ensuring appropriate use. And there's no way to decouple those. I think we as industry need to acknowledge that a new commercial model is needed. Certainly, I think government policymakers need to do that as well. But in our recognition within industry, we can't walk away from a commitment to stewardship and appropriate use. And those need to be integrated and embedded together. Any conversation about access, research, and development needs to be linked to stewardship. And I think it's critical. I can tell you at Pfizer, stewardship drives everything we do as a business. I spoke about the work that we have in the United Kingdom where we've decoupled the sales incentive for our sales force. But unlike other areas like oncology or neuroscience, where it is a volume-based market, right? You are trying to sell as many drugs as possible. For antibiotics, at least at Pfizer, we are absolutely committed to only selling the drugs to the patients who need them and ensuring the appropriate use. And that means that you're selling fewer of them. But that's what's needed to meet and address the goals of the public health and to ensure continued public health and continued access to antibiotics that we're going to need going forward.
Yeah, great. Thank you, Bruce. A quick question on SPIDAAR here, Bruce. What was the criteria for selection of the 4 countries? And can that criteria be applied to other sub-Saharan countries? And were there any anxieties or reluctance of countries to participate?
Yeah, and I'll ask you to offer some of your experiences as well. Sorry to keep jumping these back to you, but we didn't have any specific criteria. One of them was, I think it goes to how you establish these partnerships from the beginning, especially when you're initiating a novel type of partnership. It starts with relationships, and leveraging existing relationships was critical. Wellcome had existing relationships with these countries and with the governments that enabled us to be able to open the door and start a conversation. Certainly there was also all criteria around patient need, existing infrastructure, and others that were part of that conversation. But it truly was, who do we know? Who can we sit down across the table from, and eventually on the same side of the table, and explore ways in which we can work together? And I think that's what made the conversations very smooth from day one. I don't think there were ever any speed bumps, and we're certainly open to exploring expansion, not just in sub-Saharan Africa, but other regions. Their data needs go far beyond Africa. In terms of surveillance, it partially, though, I have to be very honest and transparent, it's resources. This isn't a program that's free to run. And so there's certainly challenges when it comes to thinking about how to expand, given the resource constraints that we and others have.
Yeah, there's quite a lot of interest in the chat on plans to scale up and expand SPIDAAR. So yeah, obviously we'll have to watch this space and see what happens there. Catrin, we have a question here for you. So could you expand on the outcome of data gathering processes in low and middle income countries? Is it at the local level, or do you use national figures? And what challenges do you see, and what can be done to increase the collection of this data?
That's a really difficult one to answer. Yeah. I will start by saying ours was a retrospective data collection. So this made it actually really quite difficult to get the outcome data, certainly in many places. And we worked really hard with lower and middle income countries, with researchers there, to try to make their data available so that they could use it as well as us using it. Most of our work was based on a one-to-one with researchers or institutes and things, rather than at the country level per se. So oftentimes we went to researchers that we knew had been working in the field for many years and had very good data. That was our starting point. And often, the rest of the outcome data is not available elsewhere. So there are many places where the clinical data is available on paper, but there is no record of outcome data at all. And you just have to realise that that's the case, and that, if you go back to 1990 up to today, that has been the case. I think COVID may have changed that. I think nowadays people may be tracking the mortality due to infectious diseases, which includes COVID, and the excess mortality due to COVID. I think actually what this really needs is a prospective study going forwards and collecting the data that we know we need. And that's something that we have done within GRAM, is actually realise what data is needed for this exercise and what needs to feed into it. In part, ACORN and ACORN 2, which are also funded by Wellcome, start to answer this question, as do some other projects. So it's a very difficult thing, and we've not really expanded upon the differences between high income and low income countries either here. And there are huge differences and discrepancies. I guess I would go back to this is the first step, and we'd like to make it better going forwards.
Yeah, absolutely. Thank you. Bruce, we have a question here for you on your thoughts on how advocacy and awareness campaigns can promote transparency. Do you have any thoughts on that?
Yeah, I saw that in the chat, and I was trying to think about what I would type for an answer on that. It's challenging. It's difficult. transparency comes from awareness, right? And being honest and upfront about what the data are. So I think first and foremost, we need to be transparent and honest through our awareness campaigns about what the risks are with AMR. There's only so much you can effectively communicate to the general public. So I think general awareness campaigns are a little bit different than a more focused advocacy campaign with government officials or public health officials. When you start having those conversations, you can be more detailed as to where and what the risks are associated with resistance and get more into the weeds. And again, you can start being more constructive, I think, in speaking about what each sector can bring to those conversations. So I think, awareness is a nice way to open the doors with conversations. I think, we see this with our India collaboration that I highlighted. By partnering with the Indian government around awareness building, again, it builds more trust to enable us to have more frank, honest conversations about some of the more challenging policy areas around access, et cetera, that are needed. But I think certainly through awareness, you share information, you share data, and by sharing information, it only goes to expand transparency. So, Catrin, I don't know if you have additional thoughts on that.
Yeah, I guess one of my thoughts is one of the first pillars within the Global Action Plan was actually awareness of AMR. I don't know that we're there yet in many countries. Yeah, I think we're still at the point of trying to make more people aware. The healthcare sector, yes, but reaching out from there. And I think it starts there. Have those conversations, have people understand what it is. Again, I think we're in a good place to start with COVID. People know about infectious diseases. They know it's a problem. That's a pandemic. So is AMR. Be it silent, be it volcano, however you want, be it a lobster as well. However you want to frame it, that needs to get out to general public. They need to understand what it is. I think we're starting there.
Yeah, and is there a role there for translating some of the fantastic research that we already have available, translating it more effectively into those messages that can then be understood more easily? Are we doing enough on knowledge mobilization and translation for AMR?
But it's also learning the social structures in different countries. Another project that I'm involved in, the Accelerator project, looks at the social side of AMR and taking antibiotics, the need to take antibiotics because that's culturally acceptable, that's what you do. I think we need to bring that a bit more into it. There's some fantastic social science work in this area, and we just need to integrate that a bit more with the data. And that's, I think, how we would move forward for action, really.
Yeah, we had a very interesting Gamechangers session just the other week on the social sciences and its importance. So yeah, it's a great point to pick up. I think we probably have time.
Gemma, can I just come back to one other point on this, if you don't mind? And I apologize, I didn't think of it initially, but I think it's also where and how are we working with the patient community? And how have we worked with the patient community in the past? I think as an AMR community, frankly, we failed. I think we've focused too much in the past about the fact that there isn't a patient community that is defined by antimicrobial resistance. And we haven't thought about where and how AMR impacts the broader, all patients, right? Oncology patients, hematology, be it whatever, right? As you saw on the slide, antibiotics are critical as a treatment for all treatment plans for virtually every patient. So how have we engaged the patient community to ensure that they have awareness and education? And I think we as a community need to do a better job with engaging with the broader patient community to expand their understanding about the role antibiotics play in supporting improved outcomes for their patients. There is a new AMR Patient Alliance that's starting to do this through the International Organization of Patient Organizations, IAPO. I think there's more opportunity to leverage that and think about how we engage with the patient community going forward through advocacy and transparency.
That's a really good point, Bruce. Thank you. I think we've probably got time for one final question, unless there are any burning questions from the audience that haven't been put into the chat. But I'm going to turn to a question that came up earlier about regional approaches, actually, and how so far we've touched on global and local approaches. But do you have any examples or views on how effective regional approaches can be? Catrin, do you want to take that one first?
Yeah, I'm just thinking that there are some fantastic regional surveillance projects like Webinar-4 who have really, really worked well. And I would say that's a really good start. So, you know, we start with global, regional, and then we go local. I think that would be a fantastic, you know, next step in the tiered process, I think. Regional, then go to local. But there are some really good setups already available regionally. So maybe it's just reaching out and working with them more effectively.
Yeah. Bruce?
Yeah, the regional is absolutely critical, and it makes sense, right? Within different regions, there are different sensitivities, different ways in which work is done, different needs. And so by going from global strategy and priorities to regional, then take it down to the regional level and kind of do more double clicks on that to really understand what those regional needs are. And then finally at local implementation is going to be, it's the way in which it should be done. Absolutely agree with that comment. We just need to figure out how to do it better. And maybe it's working through WHO regional offices to really start to identify what those regional priorities are. I don't think we, again, as a community, really understand the differences in Asia versus sub-Saharan Africa versus North America, and I think we need to think about that better.
Thanks, Bruce. I'm afraid we're probably going to have to finish there. Bruce, Catrin, any final words from you? You don't have to say anything, but if there's anything burning that you wanted to say, please do. You've both spoken more than enough today. In that case.
Gemma, I was just going to say thank you very much for your questions and for the excellent questions from the audience. Thank you.
Brilliant.
Exactly. Just want to thank everybody for their time today, for their attention.
Yeah, it's been a fantastic discussion. So thank you both for presenting and being here today. And also thank you so much to our participants. I have to give a few key takeaways, but I'm afraid I can't do justice to the richness of the talks and the discussion, but just a few succinct points from me. I think whilst public and private sectors have very clear roles and objectives as singular institutes and sectors tackling AMR, there is much greater value in collaboration across sectors. And I think we need to stimulate more. We haven't done enough currently. And we need to think about aligning objectives and thinking about broadening participation in our collaborations and focus on sharing knowledge and working together to ensure that knowledge is translated into action. Data and evidence generation is crucial to underpinning context-specific action, but it does require effective translation into intervention and policy to be of value, and collaboration can be a key role in that translation. We do need to focus on collaborating across sectors, both public and private, and thinking who's going to be using the outputs and involving them in the partnership. So whether that be Ministry of Health or patients, they have a very key voice and should be at the table from the beginning. We also need to share learnings of best practice on how to collaborate, focus on building trust and understanding contexts of where we're working and sharing that value of our work, and also relying on process and protocols to help smooth those collaborations. Of course, there are challenges, but we've heard from both Bruce and Catrin that we can overcome a lot of these challenges as well. So we should look to learn from examples that we've already seen. So with that, I'm going to hand back over to Satya, and thank you again, both Bruce and Catrin, for a fantastic discussion.
Thanks, Bruce, Catrin, and Gemma. It was a really rich discussion, and I was just completely glued listening to all of you. And thanks for putting in so much effort and thought into it. And a special thanks to Bruce for waking up at 3:30 or 4 in the morning to join us live. We very, very much appreciate that. I myself don't have anything specific to say. It has been excellent, and we are really satisfied with every webinar that has happened, and that has got reflected in our evaluation surveys. So it's the moment for that right now. In fact, if Jiong can put up the simple feedback evaluation form, it will take only 30 seconds for people to fill this up, and we'll be very, very happy, because we would love to share this feedback back with actually the speakers and the moderators, who are the star roles that they played for this. And also to tell you that we put the videos together, and we put short versions and summaries of the discussions, etc., all in a very short period of time onto some links that we provide, as well as send it to all the people who registered or whom we invited, not just who just participated. So, and we noticed that there are lots of people who are watching post-webinar, lots of the videos on YouTube. So they've ended up watching through the links, and we noticed 200, 250 people, they have additionally watched the videos after that, and it's been some really good stuff that has been received by all the participants. So this is really fantastic. Thank you again very much for giving us your time, and also to all our participants for all the questions. I think this one had some of the maximum number of questions, I think, and not all coming from me. I had a few, but I think a lot of them came from the participants, which was very good and very engaging. So thank you all very much. Jiong, if you're happy with the if you have received enough evaluation forms back, it's up to you, your call, to decide when you want to pull off the evaluation form. And we will, at least to our speakers and to the moderator, for sure, we'll send you the figures. They're heartening. They make you feel good. So with that from our side, I just want to thank you all once again and sign off and request that all of you do join in for the next one also. It's going to be very rich as well. It's on One Health surveillance, and we have two very good and very provocative speakers, just like today's, if not more maybe. There is Frank Astro and Thomas Beckel, and they'll be talking about, I think, animal health side of surveillance and environmental health side of surveillance. And it's going to be moderated by Sabiha, Professor Sabiha, who's from South Africa, and a very experienced person as well. And she's also vice chair of STAG AMR in WHO. And she also kindly accepted to be part of this. So thank you very much. Have a good day, good evening, whatever it is at your end. It has been very enriching for us. And I can tell you that all these materials, we hope to really put to good use during our policy workshops, which will happen at the end of the year, December or January. We'll be having a series of 2 policy workshops, and we're trying to see how we can use these to trigger some really serious discussions there too, with countries at hand at that time. So thank you once again, Bruce, Catrin, and Gemma, and also to the RADAAR team who's behind all this. You can't see them here, but there's a bunch of very bright people who have been making sure that all of you get all the messages and all the emails and invitations. Thank you very much.